Hello everyone. Today we are going to do a deep dive into vitamin B12, also known as Cobalamin. This is one of the most clinically significant vitamins in medicine, and yet it's one that's frequently underdiagnosed in practice. By the end of this session, you will have a thorough mechanistic understanding of everything from its chemical structure to its clinical manifestations, diagnostic workup, and treatment protocols. So let's get started. Vitamin B12, historically referred to as the extrinsic factor, holds a very special place in the world of vitamins. It is the largest and most chemically complex of all vitamins, with a molecular formula of C63, H88, CON14, O14P, and a molecular weight of approximately 1355 grams per mole. Now that might sound like a biochemistry lecture point, but it actually has a profound clinical implications because its sheer complexity means that its absorption, transport, and metabolism involve multiple intricate steps, any one of which can fail. Two things make vitamin B12 truly unique among vitamins. First, it is the only vitamin that contains a metal atom, specifically cobalt, at its center. Second, it is the only B vitamin that the body stores in significant amounts between 1 and 10 milligrams, with the liver being the primary depot. Now let's talk about the different forms of vitamin B12, also called vitamins or cobalamines, because understanding these forms is critical in both prescribing and interpreting lab results. Cyanocobalamine, this is the synthetic form most commonly found in supplements. It is a very stable but must be converted to an active form in the body. Hydroxycobalamine, a naturally occurring intermediate and the preferred form for intramuscular injections. It has a longer half-life and is also used as an antidote in cyanide poisoning. Methylcobalamine, this is one of the two active coenzyme forms. It works in the cytosol and serves as cofactor for the enzyme methionine synthase. This is where the folate cycle intersects. Adenosylcobalamine, the second active coenzyme form, functioning in the mitochondria as a cofactor for methylmalonyl CoA mutase. This reaction is critical for fatty acid and amino acid catabolism. Aquacobalamine, a transient intermediate form of laser clinical significance. Remember these two active forms, methylcobalamine and adenosylcobalamine, because they map directly to the two key enzymatic reactions we will cover shortly. Let's briefly look at the chemical structure of B12 because understanding this helps explain both how it works and why certain drugs and conditions disrupt it. Vitamin B12 is a coordination complex of cobalt sitting at the center of corrin ring, a tetrapyrrole macrocycle. Now, if that sounds similar to heme, you are right to notice the resemblance. But there is a key difference. Unlike the porphyrin ring of heme, the corrin ring has one direct carbon-to-carbon bond between two of its spiral rings, making it slightly smaller and more rigid. The central cobalt atom coordinates with 4 nitrogens from the corrin ring in the equatorial plane. Then we have two axial ligands. The lower alpha axial ligand, this is always the 5,6 dimethyl benzimidazole nucleotide. The upper beta axial ligand, this is the variable R group and it's what defines which form of cobalamine we are dealing with, means cyano, hydroxo, methyl or 5'-deoxyadenosyl. This upper ligand is also the reactive center and this is precisely where nitrous oxide exerts its toxic effect. Nitrous oxide irreversibly oxidizes the cobalt center, inactivating B12. We will come back to that when we discuss drug interactions. A historical footnote worth mentioning, the complete X-ray crystallographic structure of B12 was determined by the brilliant Dorothy Crowfoot Hodgkin in 1956, a feat that earned her the Nobel Prize in the chemistry in 1964. It remains one of the most complex molecular structure ever solved by X-ray crystallography. The discovery of vitamin B12 traces back to the 19th century and spans more than a century of investigation, representing one of medicine's great detective stories. The discovery of cobalamin begins in 1824. James Carth Combe first described pernicious anemia, which would later prove fatal until B12 therapy was developed. Then in 1926, George Whipple, George Minot, and William Murphy discovered that consuming raw liver could cure pernicious anemia, work that earned them the Nobel Prize in Physiology or Medicine in 1934. Then in 1929, William B. Castle demonstrated that pernicious anemia patients lack a gastric substance which he called intrinsic factor necessary to absorb the dietary extrinsic factor present in food. Then in 1948, vitamin B12 was simultaneously isolated by Carl Folkers in the United States and E. Lester Smith in England, who identified the red crystalline compound from liver extracts. In 1956, Dorothy Hodgkin elucidated the complete three-dimensional structure through X-ray crystallography. Then Robert Burns Woodward and Albert Easton-Mosher in 1972 achieved total chemical synthesis after a decade of work involving over 100 collaborators. Now we get to the heart of the biochemistry. Vitamin B12 serves as a cofactor for only two enzymes in humans, just two, but these reactions are absolutely critical for life. The first is methionine synthase, a cytosolic enzyme that is dependent on methylcobalamin. The reaction it catalyzes is homocysteine plus 5-methyl tetrahydrofolate to methionine plus tetrahydrofolate. Let's unpack why this is so important. First, this reaction regenerates methionine, an essential amino acid needed for protein synthesis. Methionine is then converted to S-adenosylmethionine, which is the universal methyl donor in the body. S-adenosylmethionine drives methylation of DNA, RNA, proteins, lipids, and neurotransmitters. So failure here has cascading epigenetic and metabolic consequences. Second, and this is a concept you absolutely must understand, the reaction releases tetrahydrofolate from its trap form. Without B12, folate gets sequestrated as 5-methyl tetrahydrofolate and cannot be recycled back into active tetrahydrofolate. This is called the methyl folate trap, and is why B12 deficiency produces a picture of functional folate deficiency and leads to megaloblastic anemia even when folate levels appears normal. Clinically, this is why you must always rule out B12 deficiency before supplementing folate. Giving folate alone can correct the anemia but will not address and may actually mask the ongoing neurological damage from B12 deficiency. The second enzyme is methylmalonyl-CoA mutase, a mitochondrial enzyme dependent on adenosyl-cobalamin. The reaction is L-methylmalonyl-CoA to succinyl-CoA. This reaction sits at the metabolic crossroads. When we catabolize odd-chain fatty acids and branch-chain amino acids, specifically valine, isoleucine, threonine, and methionine, the end product is propionyl-CoA, which gets converted to methylmalonyl-CoA. Methylmalonyl-CoA mutase then converts this to succinyl-CoA, which enters the TCA cycle. When this enzyme fails due to B12 deficiency, methylmalonic acid accumulates, and this is clinically very useful. Elevated MMA in serum or urine is a highly specific biomarker for B12 deficiency, and it's what differentiates B12 deficiency from folate deficiency at the metabolic level. We will come back to this in the diagnostic section. Additionally, this pathway is critical for myelin synthesis and integrity. The disruption of this reaction is believed to be a central mechanism in the subacute combined degeneration of the spinal cord, the hallmark neurological complications of B12 deficiency. Beyond those two enzymatic reactions, B12 has far-reaching downstream functions. DNA synthesis, through its role in maintaining the folate cycle and regenerating THF, B12 is essential for nucleotide synthesis and cell division. Erythropoiesis, without adequate B12, red blood cell precursors cannot divide properly, resulting in large dysfunctional megaloblast. Neurological function, myelin synthesis and maintenance of axonal integrity depend on intact B12 metabolism. Brain development, particularly critical during pregnancy and early infancy, where deficiency can cause irreversible neurodevelopmental damage. Epigenetic regulation, SAM-dependent methylation reactions influence gene expression across virtually every organ system. Energy metabolism, via succinyl-CoA generation and TCA cycle. So when B12 is deficient, it doesn't just affect one system, it affects hematopoiesis, neurology, cognition development, and metabolism all simultaneously. The absorption of B12 is one of the most intricate of any micronutrient. Cobalamin in food is usually in coenzyme form as a deoxyadenosylcobalamin and methylcobalamin and bound to proteins. In the stomach, peptic digestion at low pH is prerequisite for the release of cobalamin from food protein. Once it released, cobalamin preferentially binds the high affinity cobalamin binding protein called R protein, which is secreted in salivary and gastric juice. These cobalamin R protein complexes, along with unbound intrinsic factor, which is secreted by gastric parietal cells, pass into the duodenum, where pancreatic proteases degrade R proteins. This allows transfer of cobalamin to intrinsic factor. The stable intrinsic factor cobalamin complexes then pass through the jejunum to the ileum, where they specifically bind to intrinsic factor cobalamin receptors, also called cubum receptors, a complex of two proteins, cubulin and aminolense, on the microvilli of ileal mucosal cells. Within enterocytes, cobalamin is transferred to transcobalamin 2. This complex is then released into the circulation, from which it efficiently binds to high affinity transcobalamin 2 receptors on cell surfaces. When cobalamin status is compromised, this is the fraction that is primarily reduced. Only about 10 to 30% of circulating B12 is bound to transcobalamin 2 as a hollow transcobalamin, and this is the metabolically active fraction. The rest is bound to heptocorrin and is largely inactive. There is, however, another protein, transcobalamin 1, that binds to bulk, approximately 75% of serum cobalamin, but does not deliver it to cells. So it functions much like a storage protein for the cobalamin in blood. How fast B12 levels change depends on the balance between how much B12 is obtained from the diet, how much is secreted, and how much is absorbed. The total amount of B12 stored in the body is about 2 to 5 mg in adults. Around 50% of this is stored in the liver. Approximately 0.1% of this is lost per day by secretion into the gut, as not all this secretion is reabsorbed. Bile is the main form of B12 excretion. Most of the B12 secreted in the bile is recycled via enterohepatic circulation. Excess B12 beyond the blood's binding capacity is typically excreted in urine. Owing to the extremely efficient enterohepatic circulation of B12, the liver can store 3 to 5 years worth of vitamin B12. Therefore, nutritional deficiency of this vitamin is rare in adults in the absence of malabsorption disorders. Let's now look at the recommended daily intake of B12 across different life stages. For infants, the adequate intake is 0 to 6 months, 0.4 micrograms per day, 7 to 12 months, 0.5 micrograms per day. For children, 1 to 3 years, 0.9 microgram, 4 to 8 years, 1.2 microgram, 9 to 13 years, 1.8 microgram. Adolescents aged 14 to 18 years require 2.5 microgram, and this same amount applies to adults 19 years and older. Two groups with higher needs: pregnancy 2.6 microgram to support fetal neurological development, lactation 2.8 microgram because breast milk is the infant's sole B12 source, and deficiency in the mother directly translate to deficiency in the infant. These numbers seem modest, but remember, in the context of malabsorption or inadequate intake, meeting even these relatively low requirements become impossible without intervention. B12 is found almost exclusively in animal-derived foods, and this is a point with enormous clinical relevance. Let me go through the key sources. The richest source by far is beef liver. Just 3 ounces provide a staggering 70.7 micrograms, which is about 30 times the daily requirement. Clams provide 17 microgram, oysters about 15 microgram, and Atlantic salmon around 2.6 microgram, which meets the full adult daily requirement in a single serving. Dairy and eggs are modest contributors. A cup of milk gives 1.3 microgram, yogurts about 1 microgram, and an egg roughly around 4.5 microgram. Fortified nutritional yeast can provide 8 to 24 microgram per quarter cup, making it an important option for those on plant-based diets. And this brings us to the critical point. Plants do not produce B12. It is synthesized exclusively by bacteria and archaea. Plants may have a trace surface contamination from soil microbes, but this is nutritionally insignificant. Therefore, strict vegans and vegetarians must supplement with B12 or consume fortified foods. This is non-negotiable. It is a conversation every clinician should be having proactively with patients who follow plant-based diets. Now let's shift to the clinical manifestations of deficiency and talk about who is actually at risk for deficiency. We can organize risk factors into 5 broad categories. First, decreased ileal absorption. Any disease affecting the terminal ileum will impair the absorption of the IF-B12 complex. This includes Crohn's disease, ileal rejection, tropical sprue, and Diphyllobothrium latum, the fish tapeworm, which competes for dietary B12 in the gut. Second, decreased intrinsic factor production. This is arguably the most common cause of severe deficiency in clinical practice. Pernicious anemia, an autoimmune condition in which antibodies destroy parietal cells or neutralize intrinsic factor itself, is the classical example. Atrophic gastritis, particularly common in the elderly, also reduces IF secretion. Surgical causes include total or partial gastrectomy and Roux-en-Y gastric bypass. Even H. pylori infection can contribute by promoting gastric mucosal atrophy. Third, inadequate intake. Strict vegans and vegetarians, exclusively breastfed infants or B12 deficient mothers, elderly patients over 75 who have reduced dietary intake, and those with alcoholism all are at significant risk. Fourth, medications. Metformin, used long term more than 4 months, it inhibits the calcium dependent ileal receptors for the IF-B12 complex. Proton pump inhibitors and H2 blockers, after more than 12 months of use, reduce acid production, impairs release of B12 from food-bound protein. This medication category is extremely important in modern practice, given how commonly metformin and PPIs are prescribed. Routine screening in this patient is essential. Fifth, genetic disorder, those we will cover shortly. Vitamin B12 deficiency present with classic triad of hematological, neurological and psychiatric manifestations. And I want to emphasize this critical point right from the start. Neurological symptoms can occur even when the blood picture appears normal. This is not rare. It is well documented, and missing it can result in irreversible harm to your patient. Let's start with hematological picture. The signature finding is megaloblastic anemia, characterized by an MCV greater than 100 femtoliter. The underlying mechanism is impaired DNA synthesis. Without adequate THF due to methyl folate trap, cells cannot divide efficiently. The nucleus lags behind cytoplasmic development, producing large abnormal cells. On the peripheral blood smear, you will see hypersegmented neutrophils, defined as neutrophils with 5 or more lobes, or any neutrophil with 6 or more lobes. This is very sensitive and early sign. Macroovelocytes, large oval red blood cells. In severe cases, pancytopenia due to ineffective hematopoiesis across all cell lines. There is also intramedullary hemolysis. The abnormal red blood cell precursors are destroyed within the bone marrow before they even get released. This leads to elevated LDH, mildly elevated indirect bilirubin, and mild jaundice. And remember the methyl folate trap. B12 deficiency sequesters folate as 5-methyl THF, causing functional folate deficiency, meaning you can have megaloblastic anemia from B12 deficiency that looks identical to folate deficiency anemia. The neurological involvement of B12 deficiency is where things become truly serious and potentially irreversible. The hallmark is subacute combined degeneration, SCD of the spinal cord. SCD involves demyelination of two spinal cord tracts simultaneously. First, the dorsal columns, resulting in loss of proprioception and vibration sense and positive Romberg sign. Ask your patient if they feel unsteady in the dark or with their eyes closed. Second, lateral corticospinal tracts, causing an upper motor neuron picture, spasticity, hyperreflexia, and positive Babinski sign. Simultaneously, at the peripheral level, there is a peripheral neuropathy with a classic glow and stalking distribution of symmetric paresthesias beginning in the feet. The combination of dorsal column loss and lateral tract involvement leads to a distinctive gait ataxia. In chronic and severe cases, there can also be optic neuropathy causing visual impairment and autonomic dysfunction affecting bowel and bladder function. If you encounter a patient with this combination of findings, especially a mixed upper and lower motor neuron picture with sensory loss, B12 deficiency must be high on your differential and you need to act quickly because the windows for reversal narrows with time. Beyond the spinal cord, B12 deficiency can present in several other domains. Neuropsychiatric megaloblastic madness. This is term you should know. B12 deficiency can cause a full spectrum of psychiatric symptoms such as cognitive impairment, memory loss, dementia, depression, anxiety, psychosis, paranoia, hallucinations, personality changes, and rarely mania. In an elderly patient presenting with new onset psychiatric symptoms or cognitive decline, always check B12 level. It is a reversible cause of dementia that we cannot afford to miss. Mucocutaneous manifestations such as Hunter's glossitis means a smooth, beefy red tongue with atrophic papillae. Ask patients about tongue soreness or smoothness, angular cheilitis, hyperpigmentation, particularly in skin folds and the palms, more commonly seen in darker skin patients, premature graying of hair associated with chronic deficiency, gastrointestinal symptoms such as anorexia, weight loss, nausea, and diarrhea. These are non-specific but contribute to the clinical picture. Reproductive consequences. This is often underappreciated. B12 deficiency can cause reversible infertility and is associated with recurrent miscarriage. During pregnancy, severe deficiency increases the risk of neural tube defects in the offspring, independent of and in addition to folate deficiency. This is why adequate B12 supplementation in women of reproductive age is so important. Now let's discuss the genetic disorders of cobalamin metabolism. A specialized but important topic, the inborn errors of cobalamin metabolism. These are rare autosomal recessive disorders classified by complementation groups labeled CBLA through CBLJ based on where exactly the metabolic block occurs in the intracellular processing of B12. The most common and most clinically significant is CBLC disease, which causes combined methylmalonic acidemia and homocystinuria. It affects approximately 1 in 1 lakh to 2 lakh live births, making it rare but not so rare that you will never encounter it. There are two phenotypic presentation: early onset about 90% of cases, failure to thrive, hypotonia, seizures, developmental delay, retinopathy and hemolytic uremic syndrome in infancy, late onset, psychiatric symptoms, dementia, myelopathy and thromboembolism, a presentation that can be easily confused with adult onset B12 deficiency from other causes. Several other genetic disorders affect B12 handling and are worth knowing. Pernicious anemia, autoimmune. While not strictly a genetic disorder of metabolism, the predisposition to develop autoantibodies against intrinsic factor and parietal cells has genetic component. It is the most common cause of acquired B12 deficiency worldwide. Imerslund-Grasbeck syndrome, caused by mutation in the CUBN or EMN genes, which encode the cubilin amnion-less receptor complex in the ileum. This produces selective B12 malabsorption, and characteristically these patients also have proteinuria, which is the distinguishing clinical feature. Transcobalamin 2 deficiency, mutation in the TCN2 gene impair the transport of active B12 to tissues. Despite obtaining normal serum B12 levels, there is severe intracellular deficiency. These patients present with early onset failure to thrive, megaloblastic anemia, and immune deficiency and require high dose B12 supplementation. Hereditary intrinsic factor deficiency, mutation in the GIF gene impair IF production. Presentation is typical in childhood, called a juvenile form of pernicious anemia. Now let's talk about how we diagnose this. The diagnostic assessment of B12 deficiency is more nuanced than most people realize, and understanding the limitation of each test is essential for clinical practice. First category is direct B12 measurement, and this includes serum total vitamin B12. This is most commonly ordered test. The reference ranges are normal above 300 pg per ml, borderline 200 to 300 pg per ml, a gray zone requiring further functional testing, deficient below 200 pg per ml, severely deficient below 150 pg per ml. Here is the critical limitation. Serum total B12 measures mostly inactive B12, the fraction bound to heptocorrin, which accounts for about 70 to 90% of circulating B12 and does not reflect what's actually available at the tissue level. So a patient can have a normal or borderline serum B12 but still be a functionally deficient. Next is holotranscobalamin, active B12. This measures only the fraction bound to transcobalamin 2, the metabolically active 10 to 30% that tissue can actually use. It is a more sensitive marker of early or subclinical deficiency, picking up depletion before the serum B12 has fallen significantly. Normal level above 50 pg above 50 pmol per liter, deficient below 35 pmol per liter. Holotrans cobalamin is emerging as preferred first-line test in many centers and you should be familiar with it. Even more informative than the direct B12 levels are the functional biomarkers. These are sometimes called the gold standard for confirming B12 deficiency. Methylmalonic acid MMA, because MMA accumulates specifically when adenosyl cobalamin dependent methylmalonyl CoA mutation fails. Elevated MMA is specific for B12 deficiency. Folate deficiency does not raise MMA. The diagnostic threshold is above 0.27 micromole per liter in serum and it can also be measured in urine. MMA is your best test to differentiate B12 deficiency from folate deficiency. Total plasma homocysteine elevated in both B12 and folate deficiency, so it is more sensitive but less specific. When used in combination with MMA, these two tests together provide excellent diagnostic accuracy. One clinical tip: in a patient with borderline serum B12, ordering both MMA and homocysteine is the right move. Elevated MMA with or without elevated homocysteine confirms functional B12 deficiency. Now, once deficiency is confirmed, you need to work up the etiology. For suspected pernicious anemia, anti-intrinsic factor antibodies, sensitivity 40 to 60% but specificity 100%. A positive result is virtually diagnostic. Antiparietal cell antibodies, sensitivity 90% but less specific, also positive in simple atrophic gastritis. Serum gastrin elevated due to loss of acid mediated negative feedback. Pepsinogen 1 decreased due to chip cell atrophy. Gastric biopsy, the gold standard, showing atrophic gastritis with intestinal metaplasia. The skilling test, largely historical now, rarely used in modern practice. Additional diagnostic tools include hematological assessment and imaging. Complete blood count findings, macrocytic anemia, MCV above 100 femtoliter, possible pancytopenia in severe cases, low reticulocyte count reflecting ineffective erythropoiesis, markedly elevated LDH from intramedullary hemolysis, mildly elevated indirect bilirubin. In peripheral blood smear, look for macroovalocytes and hypersegmented neutrophils, defined as 5 lobes in more than 5% of neutrophils, or any neutrophil with 6 or more lobes. The smear is an underutilized tool in this context. Bone marrow biopsy is rarely necessary, but when done, show hypercellular marrow with megaloblastic erythropoiesis and giant metamyelocytes. Imaging, spinal MRI, in subacute combined degeneration, T2 weighted MRI of the spinal cord shows hyperintensity in posterior columns, producing the classic inverted V sign on axial views. Brain MRI may show white matter changes or cerebral atrophy in chronic severe cases. These imaging findings are important. If you see them, B12 deficiency should be at the top of your differential. Now let's move on to treatment, arguably the most actionable part of this entire discussion. Parenteral intramuscular therapy is preferred in severe deficiency, pernicious anemia and other malabsorption states, neurological involvement where you want rapid tissue repletion. Hydroxycobalamin is the preferred agent for IM injection because of its longer half-life and superior tissue retention compared to cyanocobalamin. The protocols are: without neurological deficits, 1 mg IM 3 times weekly for 2 weeks, then move to maintenance. With neurological deficits, 1 mg IM every other day until improvement plateaus, which can be up to 3 weeks, then transition to maintenance. Maintenance in pernicious anemia and lifelong malabsorption, 1 mg IM every 2 to 3 months indefinitely. If hydroxycobalamin is not available, cyanocobalamin IM can be used in intensive phase, 1 mg daily or every other day for 1 to 2 weeks. In consolidation, 1 mg weekly for 1 to 2 months. In maintenance, 1 mg monthly lifelong. The lifelong maintenance requirement in pernicious anemia is a critical counseling point. These patients cannot absorb oral B12 through normal mechanisms, so supplementation is permanent commitment. Here's something that surprises many clinicians. High-dose oral B12 can be as effective as intramuscular therapy for correcting anemia and most neurological symptoms, even in patients with malabsorption. The mechanism is that approximately 1.2% of B12 is absorbed passively, independent of intrinsic factor, along the entire length of the small intestine. So if you give a large enough oral dose, 1000 to 2000 microgram per day, that 1.2% passive absorption provides enough to meet daily needs. The protocol is 1000 microgram oral daily for 4 weeks, then 1000 microgram daily as lifelong maintenance. Here is the important caveat. High dose oral therapy is not the first choice for severe neurological deficit. In those cases, start with IM therapy to ensure rapid, reliable tissue delivery, then transition to oral maintenance once the patient has stabilized. Sublingual B12 500 to 2000 microgram per day and intranasal cyanocobalamin 500 microgram once weekly are alternative routes, particularly useful for patients who cannot tolerate injection or prefer a non-invasive maintenance option. Management requires a tailoring for specific patient populations. Bariatric surgery patients. Every patient who has undergone bariatric surgery affecting the stomach or proximal small bowel needs lifelong B12 supplementation. Either 1000 microgram orally daily or 1000 microgram IM monthly. This should be a part of the routine post-operative care protocol. Vegans and vegetarians. These patients need proactive counseling. Options include 25 to 250 microgram daily of oral cyanocobalamin, fortified foods, or higher weekly doses such as 1000 microgram weekly is also effective given passive absorption variability. Pregnancy and lactation in B12 deficient women. This is urgent. Treat with 1 mg IM monthly plus dietary counseling. The fetal and infant brain depends critically on maternal B12 status. Deficiency during this period can cause irreversible neurological damage in the child. Inborn errors of metabolism, CBLC and related disorders. Treatment is multi-pronged. Hydroxycobalamin 1 mg IM or subcutaneously daily or 2 to 3 times weekly obtain lifelong. Betaine 250 mg per kg per day to reduce homocysteine. Folate or folinic acid supplementation. L-carnitine for MMA buffering. Dietary protein restriction is used in some cases, though controversial in CB1C. Before we leave treatment, the one important special use of B12 hydroxycobalamin cyanokit for cyanide poisoning. The dose is 5 grams IV over 15 minutes, which can be repeated once if needed. The mechanism is elegant. B12 binds cyanide to form cyanocobalamin, which is then safely excreted in the urine. This is completely distinct from its use in B12 deficiency. Monitoring treatment response. Once you initiate B12 therapy, here's what to expect. Reticulocyte count rises within 3 to 5 days, peaking at 7 to 10 days. This is your earliest sign of hematological response. Hemoglobin normalizes within 6 to 8 weeks. MMA and homocysteine normalize within 1 to 2 weeks if treatment is adequate. These are your best biochemical endpoints to confirm response. Neurological recovery is slower, improvement may take months, and some deficit may be irreversible if treatment was delayed. This is the critical message: identify and treat early. Let's now address the safety and drug interaction profile, which is reassuring but not without nuance. Safety profile. Vitamin B12 has no established tolerable upper intake level. Excess B12 is renally excreted and toxicity at standard doses is essentially non-existent. This makes high-dose oral supplementation a very safe approach. However, rare allergic reaction can occur with injection, typically to cobalt or to preservatives in the injectable formulations. And importantly, high-dose cyanocobalamin is contraindicated in Leber's hereditary optic neuropathy because the released cyanide can worsen optic nerve damage. Use hydroxycobalamin instead in this patient. Adverse effects like injection site pain, itching and rash can occur. Headache and dizziness rarely. Hypokalemia can develop during intense correction of severe deficiency because as erythropoiesis is stimulated and new red cells are rapidly produced, potassium is taken up into cells. Monitor electrolytes, especially in the first days of treatment. Acne and rosacea-like eruption have been reported very rarely with high-dose supplementation. Vascular thrombosis is rare concern, potentially related to rapid correction in severe anemia. Finally, let's review the clinically significant drug interactions. This is something every prescribing clinician needs to know. Metformin. Metformin inhibits the calcium-dependent ileal receptor that binds the IF-B12 complex. The result is impaired B12 absorption after more than 4 months of use. Current guidelines recommended monitoring B12 levels every 1 to 2 years in patients on long-term metformin and supplementing if deficiency is detected. Proton pump inhibitors such as omeprazole and pantoprazole reduce gastric acid, impairs the proteolytic release of B12 from food protein. Clinically significant deficiency typically occurs after more than 12 months of use. Screen regularly in patients on long-term PPIs. H2 receptor antagonists such as cimetidine and ranitidine, same mechanism as PPIs to a lesser degree, screen after more than 12 months of use. Nitrous oxide, this is critical. Nitrous oxide irreversibly oxidizes the cobalt center of B12, rendering it completely inactive. Even a single exposure to nitrous oxide can precipitate acute B12 deficiency symptoms in patients who are already borderline deficient. Screen high-risk patients before surgery and avoid repeated exposures, particularly in patients with borderline B12, vegans, or those already on the edge of deficiency. Colchicine, reduce ileal absorption, monitor with long-term use in patients on chronic colchicine therapy such as those with gout or MFF. Chloramphenicol may blunt the hematological response to B12 therapy by interfering with erythropoiesis. Avoid concurrent use during active B12 repletion. And with that, we have covered vitamin B12 comprehensively, from its molecular architecture to its biochemistry, clinical presentation, diagnostic approach, and treatment strategies across special populations. Thank you for your attention, guys. I hope this presentation has been both thorough and clinically useful. Please feel free to like, share, and subscribe to the Docsaab's Diary for more high quality medical education content like this. Thank you.